so I will mainly focus on atrial cardiomyopathy. So, of course, we have to take into account that the AFNET is not a very easy chamber really to understand. And when we introduced the concept of atrial cardiomyopathy, we could see that indeed we have different substances. So coming from the electrophysiological part, we see that from mapping studies, there are substantial difference between different patient cohorts. So the underlying aspects of disease really count. So for that reason, I think it's important to understand that an atrial cardiomyopathy is not the pure consequence of atrial fibrillation. It's really present before atrial fibrillation develops. At least that's the result from many epidemiologic studies, large registries, that about 90% of patients with AF do have in advance terms of an atrial cardiomyopathy. And this is not only an electrophysiological change, it's an architectural change also in structure and function. And usually we do not focus really on atrial function, that could really have a substantial impact on the outcome of patients. And just an easy thing to understand is that the level of estrogen, for example, has a tremendous impact on tissue appearance. So the ACE and ACE2 regulation with regard to the capability of the tissue to accumulate collagen is really one major factor which can drive, of course, although throughout the time, changes in the tissue just by the aging process. And of course, just by application of estrogen to elderly male tissue, you can transform this in a more female appearance. So I think this has to be realized. And of course, we have to see that it's a continuum of different changes. For example, hypertension. So all people talk about atrial fibrillation in hypertensive patients. However, if you study this in more detail, you can see that if you take tissue from animals with hypertension, that they are not substantially different in comparison to normotensive animals. However, there's a certain period of time when actually this occurs, that there is a transition of failure of the isolated myocytes and whole tissue structure. So it's still a hypertensive animal, but the degree and the consequences are much more pronounced. So, and this really changes then also the phenotype, not only in the histological way, but also in the electrophysiological way, that the likelihood to increase the inducibility of arrhythmias substantially increases. So there is a continuum, and I think this makes the whole life very complicated because arterial hypertension does not mean the same in anybody. And for example, like the COVID animals or the COVID experiments, what we did, and also in human samples, we could see that there are new aspects of inflammatory cardiomyopathy, in particular dealing with the autonomic nervous system. Though there's an inflammation of the autonomic nervous system, this also drives then the development of atrial fibrillation and clot formation with interleukin-6 expression. So the concept probably is, and this may help to explain some unsolved issues. Also, I really enjoyed the first session this morning, that of course atrial fibrillation is a consequence of atrial cardiomyopathy and it makes the whole thing worse. So of course, to treat atrial fibrillation very early on should have an effect. However, it does not explain everything because of course there are indeed other factors driving the occurrence of thrombi without the pure presence or absence of atrial fibrillation. And how can that be explained? It can be explained because all the concomitant diseases driving the atrial cardiomyopathy do not depend on the presence or absence of AF per se, but due to the underlying mechanism like the aging process, etc. And they remain, of course, although the patient is in sinus rhythm. So, and this may explain that, for example, the burden of atrial fibrillation, and I think this is also an interesting aspect for the loop and the other monitor trials, is that really the duration of atrial fibrillation also matters. So there are candidates who will develop a stroke much more likely if the duration of atrial fibrillation with a CHEST-VASc of 2 or above is longer than 23 hours. Whereas there are also candidates with very high CHEST-VASc score values, they will suffer or may have an increased risk to suffer stroke without any atrial fibrillation due to the changes in the tissue. So it might be worth not to deal with a definition of AF longer than 30 seconds or a couple minutes, but to dig a bit more into detail what the burden or the duration, the longest duration, for example, of AF really means. So how can that be explained or modeled? There are very interesting modeling data suggesting or playing with the term atrial cardiomyopathy and occurrence of stroke. So there are interesting modeling data, and they could model tissue changes which can lead to atrial fibrillation, but also lead to a higher rate of thromboembolic stroke of so-called unknown origin. And there is very interesting work already done. So another aspect which has not been really fully covered in all the clinical trials is like atrial appendage morphology. We do know that the tissue, of course, is different with regard to atrial appendage morphology, and also that there are different appearances. And overall, we do know that the appearance of the left atrial appendage has a tremendous impact on clot formation within the atrial appendage. So we need to have imaging technologies, for example, really to discriminate between the different sizes, shape, and flow velocity of the left atrial appendage, plus duration of atrial fibrillation, etc., probably to guide rhythm control therapy. So it's even more complicated because the atrium is not just by itself. It really interferes, of course, with the ventricles, and everything interferes with everything. And one aspect which is rarely covered in all or most AF studies is a function of the mitral valve. And we do know that there is a term of atrial functional mitral valve insufficiency. And we do know that this is really affected by the shape of the atria, and restoration of sinus rhythm restores mitral valve function. And interestingly, there are many data that the restoration of sinus rhythm and to get rid of this tethering of especially the posterior part of the mitral valve reduces MI and reduces mortality in these patients. So there are many other aspects than just sinus rhythm that atrial fibrillation and atrial cardiomyopathy may have a substantial impact. And interestingly, if we focus on atrial mechanical function, and this is a very interesting paper, a couple of years ago it was published. So they determined using MRI the left atrial emptying function. So several parameters to say how the systolic function of the atrium really is in patients with heart failure. And what they showed that in addition to the presence of heart failure, deterioration of left atrial emptying function had a substantial impact on mortality in these heart failure patient populations. So it's not a passive chamber, it really counts also to hemodynamic and also to mortality. So for that reason, I think it might be very interesting really to focus on the whole appearance of the atria and the atrial function. And of course, in heart failure in particular, because we do have results from the Castle AF trial. They were highlighted this morning already, that catheter ablation might be a very interesting way to go. And of course, you have seen the recent publication from the East AFNET trial, where also Andreas really has shown that indeed, in particular also in patients with heart failure, early restoration of sinus rhythm matters. And I think it really makes sense, because if we do have an atrial cardiomyopathy up front and the development of atrial fibrillation, that indeed early rhythm control has an impact. However, we have to realize that all these factors initially also contribute to the development of an atrial cardiomyopathy. And if we could tackle all these parameters, the function of the atria in patients with normal sinus rhythm and all the other parameters, we may indeed have the best rhythm control, because these patients do not even develop atrial fibrillation and stroke up front. Thank you.